Today we have Jennifer Bell, nurse practitioner, who will be presenting on myalgic encephalomyelitis and chronic fatigue syndrome. I'm going to do a quick intro and then we'll get started. Jennifer is an advanced practice registered nurse and a certified family nurse practitioner. She's been at the Bateman Horne Center since February 2021. Jennifer has been practicing as an FNP since 1994 and has extensive experience in primary care, women's health, HIV/AIDS, and now specializing in diagnosis, treatment, research related to long COVID, ME, CFS, fibromyalgia, and related comorbidities. Jennifer was hired at BHC as part of a team to develop the first long COVID clinic in Utah. Since then, her time has been dedicated to the challenge of learning about managing long COVID along with ME, CFS, and fibromyalgia. Her time at BHC has been a culmination of an entire nursing career, bringing together her experience as a general and women's health practitioner, her interest in infectious disease and research. Most importantly, Jennifer finds deep satisfaction in working with patients who need a provider who's willing to listen and untangle the complexities of post-infection fatigue syndromes. In addition to providing clinical care, Jennifer has been a sub-investigator for 6 research studies at BHC involving ME, CFS, FM, and long COVID. In the 1990s, she was integral in the development of the Center for Clinical Studies at the University of Utah and was a sub-investigator on numerous studies for HIV/AIDS, hepatitis, and herpes. One of BHC's primary mission is to vastly expand primary care provider knowledge of ME, CFS, FM, and long COVID. Jennifer's actively participating in this mission by precepting PA students and doctoral FNP students and providing direct clinical opportunities for visiting physicians and other providers. This past summer, Jennifer was a speaker at the National Nurse Practitioner Symposium in Keystone, Colorado, where she lectured on the evaluation and management of post-viral fatigue syndrome and their comorbidities. Since then, she presented case studies for BHC's long COVID and post-viral syndrome ECHO series and University of Utah Health. Jennifer is also a lead mentor for the educational series, creating a network of knowledgeable providers around the US and Canada. Thank you for presenting. I'll turn it over to you, Jennifer.
Thank you very much for that very nice introduction. I have a lot to go over, so I'm just going to dive right in. First of all, I just want to say I have no disclosures. And the Bateman Horne Center is a center in Salt Lake City. It's a nonprofit organization that's dedicated to the direct clinical care, facilitating research and dissemination of education and resources for patients living with ME/CFS, fibromyalgia, long COVID, and other post-infectious syndromes and related comorbid conditions. The objectives of this talk today are to increase healthcare provider confidence in recognizing ME/CFS and long post-COVID sequela of COVID-19, also known as long COVID, and I'm going to refer to it as long COVID from this point on. We're also going to provide strategies for providers in the primary care setting for assessing and treating ME/CFS and long COVID ME/CFS patients. And I make a distinguish, I'm separating long COVID from long COVID ME/CFS because some people have long COVID and then some people develop ME/CFS from their COVID infection. So when I'm talking about long COVID, I'm talking about that group of people. I also am hoping that we can improve patient outcomes through targeted assessment and management of common comorbid conditions associated with ME/CFS and long COVID ME/CFS. I also have some sort of personal objectives. As you heard, I do come from a primary care background, and I understand the challenges of treating a complex patients within a busy day. At this point, there are no other specialties taking on these patients as a whole or addressing the multi-system nature of these illnesses and managing their care. So primary care is the place these patients will turn to. My goal is to give you the tools today to help you feel like you have a place to start and tools to assess and treat these patients. You are seeing these patients in your practices, and there is something that you can do about it. BHC is not a large clinic, and we have limited capacity to see new patients. There are very few clinics like ours around the country that manage these patients. So BHC is dedicated to providing educational forums like this in order to educate primary care to help those with post-infectious illnesses. So we're just going to dive right in. What is myalgic encephalomyelitis chronic fatigue syndrome? It's a mouthful, that's for sure. It's a hard one to say, but we use ME/CFS. It is a chronic, complex, debilitating, multi-system illness involving the brain with neuroinflammation, abnormal stress response, HPA axis dysregulation. It involves the peripheral nervous system, especially small fiber nerves, involving pain, sensation, and ANS dysfunction. The immune system is involved with primarily an immune dysregulation and persistent immune activation and mast cell activation. It involves the circulatory system with orthostatic intolerance and perfusion abnormalities. And it involves impaired cellular metabolism, particularly mitochondrial dysfunction, and probably more issues that we don't fully understand yet. ME/CFS is frequently post-infectious, but not always. 75% of people with ME cannot work or require a decreased work schedule. And 25% of people are home or bedbound. So it can be an absolutely devastating illness. ME/CFS is triggered by a number of pathogens. Viruses are the ones that are most common as far as we know. Herpetic viruses in particular, particularly EBV, has a tendency to trigger ME/CFS. There's also parvovirus B19, West Nile virus, enteroviruses, coronaviruses, and have now joined the ranks. Other non-viral pathogens include Giardia, Q fever, Lyme, and Campylobacter. And people with ME/CFS and long COVID share many similar symptoms, but there's a lot of heterogeneity among people, probably due to prior health conditions, systems affected, disease duration, and development of comorbid conditions. So this makes it a very challenging illness to study and to treat, because it does vary. There's no one classic algorithm that works for everybody. So how do you diagnose ME/CFS? As ME/CFS doesn't have any biomarkers or any diagnostic tests that prove a black and white diagnosis, it is primarily a clinical diagnosis. In 2015, the Institution of Medicine, which is now the National Academy of Medicine, gathered a panel of expert clinicians and researchers in the ME/CFS specialty to develop a diagnostic criteria for ME. Dr. Bateman was part of this panel. And in the blue box, it describes the major criteria that are required for diagnosis. A patient must report impairment of normal function accompanied by fatigue that's been persisting for greater than 6 months. They must also have post-exertional malaise, which I'm going to talk about in a minute. They'll have unrefreshing sleep, so that no matter how much sleep they get, they don't feel refreshed. And they must have one of the following: cognitive impairment or orthostatic intolerance. And these symptoms must be moderate to severe and present greater than 50% of the time. There are many additional features that are very common with ME/CFS, but they're not required for diagnosis. And these include chronic pain syndromes, immune inflammatory manifestations, infection manifestations, and just a word on the infection manifestations. These are people that sometimes can present with recurring flu-like symptoms that are not typical of your usual upper respiratory infection or strep infection. People often have persistent sore throats, tender lymph nodes, and low-grade fevers. They feel like they're always getting sick. And there can be neuroendocrine manifestations, particularly HPA axis dysregulation, but we don't fully understand what's going on there at this time. So quickly jumping to long COVID, the CDC defines long COVID as COVID symptoms persisting 4 weeks or more after initial infection. It can be multisystemic, a relapsing and remitting pattern with progression, and can worsen over time. It has the possibility of being severe and life-threatening even months or years later. Long COVID is not one condition. Just recently, the National Academies of Science, Engineering, and Medicine published a new definition in June of 2024. It is a more in-depth definition, and I'm going to just highlight a couple points on it. First of all, it identifies that long COVID is an infection-associated chronic condition, which aligns with other post-infectious conditions such as ME/CFS, post-treatment Lyme, and POTS, which have been plaguing us for decades. It does not require that long COVID symptoms occur continually from the initial infection. There can be a return to relatively normal function and then development of long COVID symptoms, perhaps even a couple of weeks or months later. And symptoms need to be present for at least 3 months. It identifies that long COVID can occur in children and adults. It does not require laboratory proof of previous SARS-CoV-2 infection, and it recognizes that there are no biomarkers currently available that demonstrate conclusively the presence of long COVID, and which is really important from a disability standpoint. Symptoms can be mild to severe and cause functional impairment resulting in disability from work, school, and self-care. And a few stats. These are relatively recent. According to the CDC Pulse survey that came out in May, June of this year, the incidence of long COVID in US adults is 5.3%. That calculates out to about 13.9 million adults in the US with long COVID. While not all people with long COVID develop ME/CFS, the NIH's Recover Initiative estimates upward of 87% of patients who have long COVID, which is 12.1 million people, do end up developing long COVID ME/CFS. And then we have to remember that prior to the pandemic, there were already 3.3 million people that we knew of who had ME/CFS. So now we have a grand total of at least 15 million adults in the US who have ME/CFS. And if you think about that, 75% of people with ME/CFS have to either work a reduced work life or not work at all. That has a huge impact on people's lives and our overall society. And just quickly, when I refer to long COVID patients today, I'm going to be discussing those who had mild to moderate infection, but had a lack of recovery or even increasingly worse symptoms and impairment, yet with no biological markers. Because there are kind of two groups with this. This slide is just a slide to demonstrate how the symptoms of ME/CFS and long COVID are very much alike. Long COVID has a tendency to have more decreased smell and taste and rash and hair loss. But we also have found that in ME/CFS, you can have painful lymph nodes, chemical sensitivities, and tinnitus, but we're seeing it in long COVID as well. And this slide was put out by the US ME/CFS Coalition guidelines, which talked about, it was put out in 2020. And it talks about how multi-system ME/CFS is, and it outlines some of the comorbid conditions within each system. I'm not going to go through each one of these, but this will give you an idea just of how many types of comorbid conditions can be associated with ME. Today, my focus is to talk about 3 primary comorbid conditions. There are a number of them, but I'm going to focus on 3: post-exertional malaise, dysautonomia of the autonomic nervous system, and mast cell activation syndrome. There are many others, as I said, and this is just a small list of some of the others that we see very, very commonly in our patient group. But sometimes if you can get these 3 under control, these start to improve. So let's start with post-exertional malaise. So I'm going to start with presenting a patient case. This is a long COVID patient. She's a 41-year-old woman who had a moderate case of acute COVID-19 in July 2020. Prior to that, she was a nurse's aide, and she had a very busy social and home life and was physically active. Minimal past medical history. She was sick for about 2 weeks and was able to return to work. But then a few weeks later, she started to develop a number of symptoms, including increased heart rate of 150 beats per minute, shortness of breath, vertigo, diarrhea, constipation, nausea and vomiting, tingling in her head, severe headaches, vibrations down her spine, numbness in her arms, and impaired sleep. She was seen by neurology, cardiology, internal medicine, allergy, immunology, and sleep medicine. She had an extensive diagnostic workup, and everything was essentially normal with the exception of a positive tilt table test for orthostatic intolerance and orthostatic hypotension. She had a chest CT, which showed some multifocal ground glass opacities in the lower lobes, and she had some mild obstructive sleep apnea. When she came to see me in April 2021, she was doing a little bit better, but still having a lot of symptoms of still complaining of severe fatigue, physical and cognitive impairment, worsening of symptoms after exertion, insomnia, whole body vibrations, numbness and tingling of arms and legs, anxiety, depression, mild allergy, and GI symptoms. She was on a relatively good regimen of medications. So she was on 3 medications for her orthostatic intolerance. She'd already been started on some gabapentin and was on some allergy medications. So what did I do from here? First thing we always start with is we start with a really in-depth history, and we go back to birth, and we identify sort of their health, what has happened in their health throughout their lifetime. We focus on prior infections, especially herpetic, vaccine, travel, allergy histories, psych histories, neck and head injuries. We really try to establish an understanding of what their cognitive and physical functioning was before they got ill and what happened afterwards. We always screen for ME/CFS and PEM, which is what I'm going to talk about next. We do a complete physical exam, focusing a lot on cardiovascular and neuro. We do a complete diagnostic workup as needed. We do orthostatic testing, which I'm also going to talk about. And we do cognitive testing when it's available. This can be really helpful for if you might have to help them with disability down the road. So I next determined, I wondered, does she have ME/CFS? And if so, what is her PEM like? So to determine if she has ME/CFS, we had her fill out a questionnaire, and she did meet the criteria. She had significant impairment of her overall functioning and fatigue. She had post-exertional malaise. She had unrefreshing sleep, cognitive impairment, and orthostatic intolerance. And these symptoms have been present for greater than 6 months, and they were severe to very severe and presented greater than 50% of the time. She also had some of the additional symptoms we talked about, such as chronic pain and immune and inflammatory changes. So then I wanted to get a sense of what her post-exertional malaise was all about. So what is post-exertional malaise, or PEM? People most often think of it as fatigue, but it's so much more than fatigue. PEM is the worsening of symptoms and physical and cognitive functional decline following even a small fraction of previously tolerated activities. And these activities can include physical, cognitive, emotional, social, environmental, such as temperature, noise, and lights or smells, upright exertion, and it's accompanied by severe fatigue. And the emotional exertion can also be happy or sad. PEM is often delayed 12 to 72 hours after the exertion, which makes it really hard to connect to what did I do to make myself feel this way. There is often a prolonged recovery that's way out of proportion of what the activity was. For example, a person goes to their child's soccer game and ends up feeling sick and exhausted that evening and then spends the next few days in bed. And PEM is pathognomonic finding in ME/CFS. It is not seen in any other illnesses, including those of a debilitating nature, such as cancer, congestive heart failure, and COPD.
Oh, yeah, no.
What does PEM feel like? This slide kind of represents all of the different symptoms that people who have PEM can experience. Exhaustion is usually a primary one, as is brain fog, muscle aches, but then all the rest of these things can be very much present. PEM can vary within a person and from one person to the next. Some people will experience all of these symptoms with a particularly bad PEM event, and others will experience only a handful. PEM can last for a day, a week, or sometimes months. There are many comorbid conditions associated with ME/CFS and long COVID ME/CFS, but PEM is the most devastating and life-changing aspect of these illnesses. It can be absolutely brutal for our patients. So what causes post-exertional malaise? There's a lot we still need to learn, but we do know quite a bit. We know that a significant aspect of PEM is mitochondrial dysfunction. We understand that the person experiencing PEM is unable to create enough cellular energy to maintain normal physical and cognitive functioning. We understand that people with PEM cannot remain in aerobic metabolism long enough and shift into anaerobic metabolism prematurely, and then have difficulty shifting back into anaerobic metabolism. For some of our patients, even just getting up to go to the bathroom will put them into anaerobic metabolism. Using a cell phone battery analogy, people with PEM have a battery that runs down too fast and a battery that will not recharge at a normal rate. They may use up their battery life all at once with a major exertion, or they may repeatedly overexert just a little, never fully recharging their battery up and end up in PEM days later. People with PEM will also have good days where their functioning is better, but not normal. They will also have bad days where their functioning is more severely impaired from their baseline function. The bad days are the physiologic state known as post-exertional malaise. We also know that repeated PEM events and/or prolonged PEM events will decline the person's functioning from their baseline functioning permanently, furthering long-term disability. So if they have a bad PEM events or multiple PEM events, they will lose function permanently and they can't get it back. So it is very, very important to screen our patients for PEM so that we can help them avoid that. What's the science behind this? Well, there's been a number of studies using 2-day cardiopulmonary exercise tests that have increased our understanding of PEM. CPET testing involves using an exercise bike with increasing resistance over 20 minutes and measuring physiologic metrics such as VO2 max, vital signs, EKG, and CO2 levels, to name a few. This enables measurement of physiologic output and stress on day 1 and day 2 of testing, and the testing are on two contiguous days. What they found is that in general, healthy individuals and those with chronic illnesses such as COPD, cystic fibrosis, CHF, and pulmonary hypertension have found that they have a low variability in performance between the first day and the second day of CPET testing. So they can perform pretty similarly on both days. However, when they compared these two groups to ME/CFS patients, they found that ME/CFS patients could perform relatively equally on day 1, but then on day 2, people with ME/CFS had significant reduction in their function as compared to the two groups. This is unique to patients who experience PEM as part of ME/CFS. And also importantly, this is shown to be independent of effort, which can be accounted for in CPET protocols. This study looked at what happens 48 hours after 2-day CPET testing. There were 25 subjects with ME/CFS and 22 matched healthy but sedentary controls. In the control group, 85% had recovered by 24 hours, and all had recovered after 48 hours. In the ME/CFS group, nobody had recovered in 24 hours, and only one subject had recovered at 48 hours. And then a recent study came out in February 2024 with 25 long COVID persons with lingering symptoms and PEM were matched with 21 healthy persons who had fully recovered from their COVID infection. Participants were put through maximal exercise testing, blood samples and muscle biopsies were taken before and after testing. What was found was lower exercise capacity in long COVID ME/CFS patients was associated with greater proportion of highly fatigable glycotic fibers. There was also local and systemic metabolic disturbances and exercise-induced worsening of myopathy and tissue infiltration of amyloid deposits in the skeletal muscle. So there definitely is a lot going on metabolically in these patients. So how do you determine if somebody has PEM? 2-day CPET tests can be helpful, but they can be extremely detrimental to patients with PEM. We've had patients who've gone through either CPET testing through research or for disability and sometimes not recover from the testing. They have such a significant PEM event afterwards that they never fully recover. So CPET testing for diagnosis is very risky and not recommended. So we're back to really listening to our patients, and patients will provide you with the information you need to diagnose PEM. If you hear statements like, "I never recovered from my illness," "I can't exercise anymore. Exercise makes me feel worse. I can't work, but then I have no energy left after work or for the weekend. And I'm always exhausted. Sleep doesn't make me feel better." Those statements should raise your suspicion that PEM exists. You can ask further questions and ask them, does it take you a day or more to recover from exertion? And remember, this can be physical, cognitive, or social and emotional exertion. Or do you experience any other symptoms with fatigue, such as feeling fluish, increased pain, GI symptoms, anxiety, poor sleep? I think this last question is really important because a lot of people focus on the fatigue and they aren't thinking that all these other symptoms they're experiencing are part of what's going on with them. So I think it's important to ask them if they're having any of these other symptoms. And if they answer yes to that, then you need to really consider PEM. Another way to screen for it also is an activity tolerance assessment. We look at hours of upright activity and good day, bad day questionnaire. For hours of upright activity, or HUA as we call it, it's basically you're asking the patient, how much time do you spend with your feet on the floor in a 24-hour period? And that could be standing, seated with your feet on the floor, or walking. It's not with their feet elevated or tucked up underneath them. Normal, healthy folks have a HUA of 14 to 17 hours a day. And people with chronic illnesses such as MS, rheumatoid arthritis, CHF, COPD, and fibromyalgia have a HUA of 10 to 12 hours per day. ME/CFS and long COVID patients have a HUA of 0 to 7 hours per day. Then you can ask them a couple simple questions. How many good days do you have in a month? And that's very subjective, but you ask them, what would you consider a good day? And how many bad days do you have in a month? And then you ask them to give examples of what activities they can do in a good day and a bad day. And what activities can they do or can they not do, on a good or a bad day. So you're getting an idea of what their function is. This is a QR code that will provide you with a questionnaire that you can use in your clinic. So let's go back to our patient. When she came to our clinic, she had 5 good days a month. She had 6 hours of upright activity. She could sit and walk in her house. She could go to the mailbox, unload the dishwasher, and make a simple meal. She could not walk more than a block, watch TV, and showering was hard. She had 25 bad days a month. So that's not a great ratio of 5 to 25. She had 3 hours of upright activity. She could sit up and brush her teeth, eat a simple meal, and sleep. She could not stand for greater than 5 minutes, cook, watch TV, do basic hygiene, or even talk on the phone. It gives you an idea of how impaired she was. So you have the person come in, you do this testing, and you identify that they have PEM. What can you do for them? There's no magic medication or therapy or post-exertional malaise at this time. However, what we do know is that pacing can be effective in preventing post-exertional malaise. And remember, we're trying to help people utilize their energy in a way that keeps their battery levels at least 50% more charged, and trying not to drain their battery down. And some of the things we can do is educate them early and often about PEM, which means we have to educate ourselves about it. And it is a concept that is hard to sort of grasp if you're not familiar with it. So it takes some time. So I encourage you to do some reading, watch some of the videos that we have on our website that explain PEM. We also provide our patients with an ME/CFS crash survival guide, which is also on our website. And that can really explain kind of the nuances of PEM and what to do about it. We talk about modifying activities. How can they preserve their energy? Shopping online, using delivery services. We identify priorities and we have them identify priorities and cut out unimportant things, using timers to make frequent rest breaks. If you have occupational therapists or physical therapists who are knowledgeable about ME and PEM, they can be really helpful in helping you help your patient understand PEM. And just some takeaways about PEM. Just remember, repeatedly exceeding energy capacity results in worsening illness. And that energy expenditure can occur with all sorts of different types of activities that I've listed here. And that all these expenditures combined will rapidly use up limited energy. The threshold for triggering PEM varies day to day, at stages of illness, and from person to person. It can be very challenging for you as a provider and a patient to understand how PEM is playing a role in their illness. It just takes time and just listening to your patient. Pacing is critical. The more PEM is prevented, the more likely the patient's illness will stabilize and then will start experiencing improvement. It is also important to treat all the other comorbid conditions. But if you do not get PEM under control, the patient will not truly stabilize and improve overall. So that was a quick conversation about PEM. So the second thing I wanted to talk about was dysautonomia. So what is dysautonomia? It is a dysregulation of the autonomic nervous system, primarily sympathetic overdrive. Patients are basically in a constant state of fight or flight. which is exhausting and uses up a lot of battery power. Their parasympathetic system is being overrun by the sympathetic nervous system. I've listed here a number of symptoms that patients can have with dysautonomia, but I've highlighted the bottom one, orthostatic intolerance, because that is the one that is you want to focus on first. We call it the low-hanging fruit in our clinic, because if you can get orthostatic intolerance under control, then a lot of these will improve. So what is orthostatic intolerance? This basically means that a person cannot tolerate being upright for very long. So all these activities make them want to lie down. To be a little more scientific about it, when transitioning from lying down to sitting or standing, gravity exerts a force that decreases overall blood flow in the brain. Healthy people are able to adapt to the force of gravity and maintain blood flow to the brain through activation of the autonomic nervous system, which detects the change in position and sends a multitude of signals that help blood vessels constrict and maintain a similar amount of blood flow to the brain when upright. In dysautonomia, these initial adaptive features of the autonomic nervous system are inadequate to maintain enough blood flow to the brain to function optimally. And if you have somebody with a low, normal, or high blood pressure, they can still have, blood pressure in the seated position or at rest, they can still have orthostatic intolerance. So it's important that you screen for it properly. And I encourage you to screen every single person you have for orthostatic intolerance. The kinds of symptoms you might see with orthostatic intolerance are cerebral underperfusion symptoms, such as lightheadedness, fainting, impaired cognition, disorientation, headaches, visual changes, unusual neurologic symptoms, and exhaustion. The peripheral cardiovascular symptoms include sympathetic nervous system activations, palpitations, nausea, abdominal and chest discomfort, facial pallor, cold hands and feet, anxiousness, shortness of breath, sweating, and tremor, to name just a few of them. And there are 4 defined syndromes of chronic orthostatic intolerance, or OI. Postural orthostatic tachycardic syndrome is the one that gets most of the attention. It's fairly common in long COVID, and it's definitely a big part of our population. But you can also have orthostatic hypotension, neurally mediated hypotension or syncope, and orthostatic hypertension. However, it's not only however, these 4, you need to be willing to read between the lines, because some people have orthostatic intolerance but don't necessarily meet exactly each one of these criteria. People can sometimes have less pronounced OI on good days, and on bad days they might have full-on POTS. If someone has a low HUA and a poor ratio on their good day, bad day, they most likely have orthostatic intolerance. So stay attuned to that and don't rule it out too quickly. So our patient, she came to us, she couldn't stand or sit up for very long. She had tachycardia, shortness of breath, labile blood pressure, and labile heart rate. She also had dysautonomia symptoms of whole body vibrations, burning and tingling of her arms and hands, increased anxiety, and ADHD. She had a disrupted sleep that was a wired but tired experience. She was already on some medications which were pretty good. We just needed to make some adjustments in dose. Her hydration was pretty good, but we needed to increase her water and her sodium intake. And her compression clothing, she was doing great with wearing compression. We just needed to add a little bit of abdominal compression. So how can you tell what kind of orthostatic intolerance a patient has? An in-office standing test can be an alternative to the tilt table test, which is expensive and hard to get. In our clinic, we use a standardized passive standing test called the 10-minute Nasaline test. The passive nature of this test is that the patient leans against the wall instead of actively standing in the middle of the room. A passive test reduces skeletal muscle activity, giving you a clearer understanding of the neurovascular system's response to standing. Dr. Bateman started using this in our clinic in 2015 on her long-term ME/CFS patients. The Nasaline test gave her a quick and accurate way to screen for dysautonomia, and the results were dramatic and changed the way she treated her patients and significantly improved many patient outcomes. The Nasaline test is a simple, inexpensive test that you can train your staff to do. It involves having a patient lie down for 15 minutes in a quiet, darkened room. You will then come in and take a blood pressure and heart rate readings while they're lying down, and then calmly move them to a standing position to the wall, where they'll have their heels about 6 inches from the wall, and the only part leaning against the wall are their shoulders and the back of their head. And then you will check their blood pressure and heart rate every minute after that and monitor their symptoms. And you do that for a full 10 minutes. Let's look at our patient's Nasoline test when she came to us. She was off all of her medications for this. She had a seated blood pressure of 120 over 80, so not very remarkable, but her heart rate was 110. So right there, that tells you something's not right. Lying down, her heart rate was still quite high, and her diastolic pressure was pretty high lying down. But what was interesting was when she stood up, her heart rate jumped up 30 points. So right there, she met PASC criteria of 30 beats per minute and over 120. And then her tachycardia increased to 136 beats per minute after 10 minutes. So she had a 38 beat per minute increase. Her systolic and diastolic blood pressure had some changes. Her systolic dropped by 20 millimeters of mercury, and her diastolic increased. This resulted in a narrowed pulse pressure, which caused a decrease of venous blood flow back to the heart and decreased cardiac output. Anything under 25% is considered pathologic, and the closer it gets to 0, you're going into you're nearing stroke. She got down to 9% during her lean test, and I'm surprised she was actually able to finish the test. Her symptoms over here were not good. Again, I was surprised she was able to do it, and by 10 minutes she was lightheaded, dizzy, and had heaviness in her limbs and was sweating. So one of the symptoms we see is venous pooling or mottling or acrocyanosis, and you will see feet that become red, and feet and hands that become red and engorged, and then eventually become purple and cold. And sometimes this mottling or acrocyanosis will move up to the knee and the elbows, and it is a symptom of the blood pooling down there and not being able to get back up. We understand this to be secondary to nerve injury. The loss of myovascular innervation can result in vessel leakage that leads to premature arteriovenous shunting of the blood. Capillary beds can be entirely bypassed in this distal left to right shunting. The longer the patient stands, the more profound the premature shunting. This leaves unoxygenated blood in the distal extremities, which causes toxic waste buildup. Additionally, this shunting is not adequate to perfuse the brain, so the brain will do everything it can to get the person to lie down, sometimes resulting in syncope. Switching gears to mast cell activation. In 2018 and 19, the ME/CFS clinician and research community was starting to pay attention to the possibility of mast cell activation syndrome playing a role in ME/CFS. When long COVID came along, it greatly expanded our understanding of the connection of MCAS and post-infectious illnesses. And we now understand that MCAS can be one of the main drivers of long COVID in general, ME/CFS, and long COVID ME/CFS. So what are mast cells? Mast cells are a type of immune cell that controls most connective tissues, as well as neurologic and brain tissues in the body. They are pretty much everywhere. Mast cells are traditionally known to be involved in mediating allergic responses. When they are activated by IgE, antibodies, and other triggers, they release over 90 inflammatory chemicals, with histamine and leukotriene being the ones we are most familiar with. Mast cells are present throughout the body system. If one system is affected, the mast cells may send distress signals through the nervous system and immune system to other areas of the body, alerting other mast cells to activate as well. A good example of this is if you eat some shellfish, you may have GI upset, but you also may develop hives and angioedema of the upper respiratory tract. And so that's activating at least 3 systems. In mast cell disorders, mast cells can become activated by nearly any exposure to foreign substance, completely independent of the traditional IgE or other immune system triggers, for reasons we don't fully understand. when mast cells are dysregulated, there can be a number of triggers that aren't IgE mediated. And many of these can be things such as weather changes, temperature changes, stress, whether it's emotional or physical, exercise, food, drugs, contrast dyes, odors such as perfumes and chemicals, other infections, sunlight, friction, or vibration. If you have a severe case of mast cell activation syndrome, it can be really difficult to live in this world because everything can set it off. When you screen a patient for possible mast cell activation syndrome, you want to ask questions about allergy symptoms in multiple systems. If 2 or more systems are involved, it should heighten your suspicion of MCAS. I'm not going to read each one of these, but I mostly want to highlight a couple of things. The GI system seems to be very affected by mast cell dysregulation in ME/CFS and long COVID ME patients. If you see IBS type symptoms, then mast cell should become an increased suspicion. And many of the symptoms many of the symptoms can be neurologic and cardiovascular appearing, and so they can also be attributed to dysautonomia. So sometimes it can be difficult to tease these apart as to whether this is mast cell or dysautonomia. But we do know that mast cell activation syndrome and dysautonomia will exacerbate each other. So if POTS is out of control, then it may trigger mast cell symptoms. And if mast cell symptoms are out of control, then it may trigger POTS. So controlling both is really important for overall management. Some patients may not have mast cell symptoms at all the time, but when they are in PEM, they may all of a sudden develop GI symptoms, flu-like symptoms, hives, etc. These patients have mast cell activation syndrome, but it's not that bad unless they are in PEM. And these patients, you might want to consider treating them either for mast cell on a regular basis or making sure they have it available to them when they have a crash. So our patient, she had mast cell, she had 5 systems that were affected. Oh, sorry, I keep doing that. 5 systems that were affected. She didn't have severe mast cell. I'm getting messaged here. Hold on a second. Okay, and the medications she was on were actually pretty effective for managing this. So I didn't really make any changes in the beginning. Okay, so I'm just going to talk a little bit about diagnostics and treatment here. So just remember a couple of things. Before you start doing the treating, you want to make sure you do that thorough history, use the screening tools and questionnaires. You want to make sure you do that good physical exam, any diagnostic workup, which I'm going to talk about in the next slide. Orthostatic testing, please do this on everybody. Any patients that you wonder might have long COVID or ME/CFS. Cognitive testing, and remember to do the good day and bad day questionnaires and screening for ME/CFS and PEM. So diagnostic laboratory tests, there are a lot of them here. Sometimes I do a good chunk of them. I don't do all of them. It will depend on what they've already had done. But we do look at a lot. We're trying to rule out other possible causes for illness and also to try to help understand their ME/CFS illness as well. We found that many of our ME/CFS patients and long COVID patients will have low ACTH and low cortisol levels, which may be part of the HPA axis dysfunction. I always screen for autoimmune, but I don't usually find much in the way of autoimmune illness. Nutritional deficiencies might suggest mast cell. They seem to always be getting sick. And they maybe have history of herpetic infections. I would want to check for these. We know that these viruses are known to be reactivated in ME/CFS and long COVID, and antiviral therapies can be helpful with some of these patients. I will get an immunoglobulin panel if someone has a lot of recurrent URI illnesses. And then my next slide is about allergies. Allergy testing is a little controversial. In the allergy immunology world, they really rely on, as far as I understand, they rely on allergy testing for diagnosis. What we find is that these patients often, unless they're in a full allergy flare, we won't get positive testing. And you have to make sure if you're going to do the allergy testing that you have them off their antihistamines and leukotriene receptor antagonists for at least 4 days prior to testing. We primarily treat empirically. If we have a clinical suspicion for MCAS, then we will start treating. And we have had incredible success with starting patients on MCAS therapy if we have a strong suspicion that MCAS is there. Sometimes we'll see elevated tryptase and histamine levels. And if we do get any kind of biopsies like through endoscopy, that's always helpful, but it's not what we rely on for treatment. It really is a clinical diagnosis for us. We will also get other diagnostic tests as appropriate. I usually always get an EKG and an echocardiogram because I want to check their cardiovascular status, because most likely I'm going to be using some fluids. So if a patient's in a crash, we don't, as I said, we don't have any kind of magic or medication that fixes this. What it's really about is resting. So you really get them to rest, unplug, reduce any activities, any exertions at all, if at all possible. You want to have them hydrate aggressively orally with water and sodium as appropriate for their cardiovascular status. If they're too sick and having too much trouble with consuming water and sodium, then you can do a 1 to 2 week course of IV normal saline, a 1 liter of IV fluids every other day for 2 weeks. And this can sometimes help stabilize somebody in PEM and help them come out of it sooner. It also can help them appreciate how much fluid replacement makes a difference. If they're not already taking antihistamines, they could use H1 and H2 blockers, which can sometimes settle down mast cell presentation in a crash, and that can sometimes help stabilize them. Off-label, we'll use dextromethorphan, the DM or Robitussin DM. We use the 15 milligram soft gels every 1 to 3 days. We found that it helps reduce sympathetic overdrive and can sometimes help reduce that dysautonomia. We are careful initiating any other therapies, though, during a crash, because people can be very medication sensitive during this time. And then as they start coming out of a crash, we focus on PEM prevention and pacing, because sometimes when somebody finally starts feeling better, they want to jump back out into the world and they put themselves into a crash again. Medications for fatigue and energy. Again, I mentioned dextromethorphan. We also use low-dose naltrexone, which is primarily used for fibromyalgia, but we've also found it to be very beneficial for cognition and energy in long COVID patients and also ME/CFS patients. The goal dose is usually 4.5 to 6 milligrams at night, but you need to increase the dose slowly. Usually starting at 1 milligram, moving up to 2.5, and then moving up to 4.5. I've outlined a couple ways you can prescribe low-dose naltrexone, either through compounding or utilizing naltrexone 50 milligram tablets and dissolving it in distilled water. Stimulants can be also helpful, but you have to use these strategically. The external sort of energy source that it provides can also cause PEM. Intervention to improve orthostatic intolerance. If you think about what's happening physiologically, if the vessels in your lower extremities are not contracting to push that blood up, then what you need to do is add more fluid to the vascular system through water and sodium. So we are very aggressive with hydration. Assuming there are no cardiac issues, I will start with 2 to 3 liters of water per day with 500 to 1,000 milligrams of sodium per liter of water. Some patients can tolerate more, but some patients have a little harder time with this. What I find patients sometimes have an issue with is their stomach can't tolerate the sodium. They have fluid retention in their extremities, headaches, and sometimes elevated blood pressure. So you need to monitor for this. But I would say the majority do tolerate it. Compression clothing is very helpful from the ankles to the lower ribs, and compressing the abdomen is super important, as that's where a lot of fluid is retained. And during hot weather like we're having now, I often recommend shapewear, partly because it's abdominal and upper thigh compression, and it's also made with lighter weight materials that are a little more breathable during hot weather. Some medications for people who have an orthostatic hypotensive presentation. Fludrocortisone can be very, very helpful to help that water and sodium that they're drinking stay in their vascular system. Midodrine and droxidopa are alpha-1 agonists, and they promote vascular constriction of the extremities and in the abdomen to help improve perfusion of blood to the core and the brain. These medications are best tolerated if you slowly up titrate the doses. And also you want to make sure people are really well hydrated when they're taking alpha-1 agonists, or they can have a lot more side effects. Beta blockers are often a foundational treatment for managing POTS. They're particularly good if somebody has tachycardia and a hypertensive response to standing. However, if somebody's heart rate is going up because their blood pressure is dropping, then I will often want to treat that blood pressure and support the blood pressure as opposed to trying to reduce their heart rate directly. So I'll use fludrocortisone, midodrine, or droxidopa to support the blood pressure. And then one other medication we use, pyridostigmine, is an acetylcholinesterase inhibitor. It's approved for myasthenia gravis, but it's recommended in the literature for POTS and orthostatic hypotension. It works by raising the neurotransmitter acetylcholine at the neuromuscular junction, and it's a weak stimulator of the parasympathetic system. So it helps improve skeletal muscle contraction, improves venous constriction and venous preload return back to the heart. It also helps reverse the premature arteriovenous shunting and improves tissue oxygenation and removal of metabolic waste from the distal extremities. Pyridostigmine does really help. It can sometimes help people not go into PEM as easily. It does have some GI side effects, so you have to start low and go slow on the dose. And if I can shift people to an extended release formulation once they can tolerate the dosing, then they often do better on that. Other treatments that can help treat sympathetic overdrive are things that you're managing your comorbid conditions, your vagal maneuvers, anything that stimulates the parasympathetic system can be very helpful. Neuroplasticity programs are also helpful in improving sympathetic overdrive. Benzodiazepines can be good in a pinch when somebody's really having problems, but we don't want to use them on a regular basis. Stellate ganglion block, I'm not going to get into this, but this is a procedure that's being looked at closely, particularly for long COVID dysautonomia, and there are a number of studies underway looking at this therapy. Mast cell activation treatments, there are a lot of them, and sometimes people are almost on all of these. I'm not going to go through each one, but I just will make a comment. The H1 blockade is particularly important if people have upper and lower respiratory symptoms. H2 blockade can be helpful for GI symptoms. Leukotriene blockade, particularly helpful with respiratory symptoms. Mast cell stabilizers are sometimes a place that I'll start as well. Liquid cromolyn, it's covered by insurance. It can be cumbersome to take 3 or 4 times a day, but it's often very effective at settling down mast cell activation. You do need to start slowly and move up slowly on the dose. 2 compounded medications, cromolyn and ketotifen, are also very effective. They're not covered by insurance, which is not great, but cromolyn can be particularly good, particularly if they have headaches and a lot of dermatologic symptoms. And compounded ketotifen can be really helpful if they aren't tolerating gastrochrome. Quercetin is a little supplement that I've been using more, and I use that a lot with people who maybe have mild mast cell symptoms. And then allergists often will prescribe anti-IgE biologics like omalizumab, and this can be helpful for somebody who's not responding to the above treatments. Diet is super important to reduce inflammation, and remind your patients that they need to freeze their leftovers as soon as possible and then only eat those leftovers that have been frozen. DAO supplement can help improve histamine metabolism. We talked about diphenhydramine for when somebody's in a crash. And steroid inhalers and nasal sprays have a role, but they're not a primary treatment. So back to our patient case. I saw her about a month ago. She now has a HUA of 8 to 10 hours a day. So that's better than 3 to 6. Her good day, bad day ratio has improved a lot. She's 70% good days and 30% bad days. She's working part-time 5 days a week, and she's able to go to church, which was one of her big goals. We made a lot of changes to her regimen, but pacing and PEM avoidance was the thing that really stabilized her. And then the medications and all the treatments really started turning things around. We increased her propranolol, added pyridostigmine, added dextromethorphan. We upped her hydration. She does 4 to 6 liters of water a day and 2,400 to 3,600 milligrams of sodium per day. She is very good about wearing her compression, and it really has made a difference. She was finally strong enough to be able to do PT for strengthening, and she was very careful with this. Many of our patients, particularly with POTS, are prescribed graded exercise PT, which is fine if somebody doesn't have PEM. But if they have PEM, graded exercise can be really, really hard on these patients and can actually make them worse. So you want to try to find a physical therapist who understands about ME/CFS and PEM. But she was finally able to do some very low level PT for strengthening. Her mast cell symptoms, we did change up her mast cell regimen, and she's doing very well now. She's on a little bit of low dose naltrexone, and her sleep and anxiety is better. And for my final slide, just this is sort of strategies for caring for these patients. You just want to identify the most significant complaints and address them first. Again, screening for ME/CFS, PEM, orthostatic intolerance. You might need to see these patients every 2 weeks at first to get a handle on them. Get your labs and diagnostics early on. If you need to refer to specialists for more advanced testing, do. Start only 1 to 2 therapies at a time and give them time to work. Start with low doses and work up slowly, and have a patient keep a symptom and health journal. Be prepared for setbacks because they will happen. They'll get COVID again or something like that, and you feel like you're starting back at square one. And then when you're charting, just think about disability, because a lot of these people end up needing to apply for disability. The last couple slides are some QR codes that are available to you that will take you directly to our website. And I encourage you to take a look at them. We have a ton of information in there. And I know this was rapid. I thank you for your attention. And thanks very much.
Thank you so much, Jennifer. That was really helpful. And we will be sending out the slides with the links of the questionnaires that were included in today's talk. That is our time. I appreciate you giving us this talk. It was really helpful. See you, everybody.